Hi, and welcome to your sexual health update. My name's Rachel, and I've got a background in contraception and sexually transmitted infection in various clinics in the city. Some of the topics that we're going to cover today is about the evolution of the sexual health services, emergency contraception, pill regimes, vaccinations, missed pills, spotting the signs, about a recent study which was talked about in the Faculty of Sexual and Reproductive Health, and an STI overview. Some of this information that we might talk about, you might already know, but it's always worth kind of like refreshing your memory to make sure you're doing things correct. If sexual health is something that you're interested in and you want to know more about, then there is a course on the Health Academy if that's something that you want to do and you can look into. So just a bit about the evolution of the sexual health services. So if you are working in a sexual health service at the moment or a place that delivers sexual health services, you're probably already aware that funding cuts have had an impact of the sexual health services. So in 2013, it was decided that the sexual health services would be commissioned by the local council. Since then, the sexual health services, like most places in the NHS, has been put under like very intense pressure financially, as they were asked to reduce the funding to the sexual health services by 24% between 2015-16 and 2020 and 2021. So that meant that across England, the spending on STI testing, contraception, and treatment decreased by almost 17% as the local councils implemented these cuts. So there were quite a lot of changes. For example, in our area, the satellite clinics got closed. There were two different clinics in the city, so we merged to one. So there has been a lot of differences, a lot of changes to try and get through the spending cuts, the cost cuts that we've had to do. And then the next thing that the sexual health service, as well as globally, had to have more pressure was during the global pandemic. Obviously, everything changed in regards to the sexual health services. A lot of our staff needed to move to the hospital clinic, so there was only a small amount of staff left to staff the sexual health services. So it wasn't seen as an emergency service. So there weren't that many staff, and we had to do telephone triage. We had to do online testing, which we were already doing in a small amount, but majority of the testing was online. So people would be ordering their tests online, which that has actually stuck. So telephone triage is still happening following the COVID pandemic, and so has online testing continued. If online testing is something that you do in your area, there is actually on the there's some standards on the Faculty of Sexual and Reproductive Health about online standards for STI remote providers. So if you just Google that, you'll find some more information to make sure that you're doing things correctly. So a lot of things have changed. One of the, I think, not all for the bad. Sometimes it has been a benefit, especially for the patients, because online testing has made it a lot easier for them to access the service rather than coming in between certain times when they might be working. And telephone triage has helped because it means that we can direct patients to the correct services. Another bonus has been the over-the-counter contraception, so people can get the progesterone pill over the counter. which is good in one respect because they can get the contraception they need rather than trying to get into an appointment for sexual health services or a GP. But the downside about it is the cost, and obviously with the way things are financially at the moment, it's something that not everyone is able to do, unfortunately. So just a bit about emergency contraception. Most services offer it, so obviously you can get it from pharmacies, you can get it from GP services, you can get it from the sexual health services. A&Es provide it if it's emergency as well, and it's really important that you're aware of the most up-to-date research. So you always have to make sure that you advise on all options for emergency contraception. So you shouldn't be just advising the contraception that you've got. So if you only give Ellaone or you only give levonorgestrel, you shouldn't just be offering those two types of contraception. You should make sure that the patient is aware of all types of emergency contraception. So the Faculty of Sexual and Reproductive Health, so the FSRH, advises that all clinicians should be informing the patient about the copper coil because it is the most effective method and it should always be discussed. If you are unable to do the copper coil there, then that's absolutely fine. You should still be talking about it and then signposting them to the appropriate services. So whether you ring up the sexual health service or talk to your GP, if they're able to fit coils, and see when they can fit them in, the soonest time they can fit them in, because obviously with emergency contraception, it's quite you're quite restrained by the times. If the patient is wanting the emergency coil and you can't do it there and then you should always be giving oral emergency contraception just in case when they do go back to the appointment, if we are unable to insert the coil or the woman changes the mind, then it's just the time it might be 4 or 5 hours down the line, and the longer you leave the emergency contraception, the less effective it is. So it is important that if you don't insert it at that point in time, that you give the oral emergency contraception, explain the reasons why you're doing it to the lady or the person. Ellaone has been demonstrated to be more effective than levonorgestrel, and it's really important. So I think about maybe 4 years ago, the new research came about that higher weight or BMI can affect the effectiveness of oral emergency contraception, in particular levonorgestrel. So it's really important that you are doing their height and doing their weight to work out their BMI, and it has to be a recent one. Obviously there are some restraints that you might have, and you just need to think about that. So if you haven't got a height and weight machine there, you might want to think about getting one. And although the patient might have been recently weighed themselves, you don't know whether their weighing scales are correct and everything like that. So that's something that you need to think about. So there is a guidance at the Faculty of Sexual and Reproductive Health, which is a section all about emergency contraception. And it's actually got a really good decision-making algorithm for emergency contraception. So I would advise you, if you are giving emergency contraception, whether you're prescribing it or doing under PGD or asking someone else to prescribe it for you, that you do have a look at this algorithm. So it helps you decide which is the best method, whether it's Ellaone, whether it's levonorgestrel, or whether it's the copper coil, which is the most appropriate depending on when they had sex, where they are in their cycle, if they've had any other unprotected sex in that cycle, So there's quite a few things that they can consider, and it helps you to make that decision. So that's the algorithm 1, and the algorithm 2 is which one should you have if you're having oral emergency contraception. Which one would be better, levonorgestrel or the ELA1, so olopristral acetate. So with levonorgestrel, if the person is their BMI is above 26 or the weight is above 70, they do say that you should be considering doing a double dose of levonorgestrel, so 2 levonorgestrel rather than 1. So that is something that you need to be thinking about when you're prescribing the medication, and whether it's worth giving the levonorgestrel or the olopristral acetate. So you do need to think about that, and I would advise you to use that algorithm because it is really, really good to use and helps you to make the decision. But ultimately, you need to be giving all the information to the patient and letting them make the decision, because they're the person who should be making the decision. You give them the information and they decide which is best for them according to the information that you give them, and making sure that you give the appropriate leaflets, or they're able to access online the information about the method that you gave them. So in regards to pill regime, it's quite often it's been common that most people give them the standard regime. So you take it for 3 weeks, have 1 week off. It has changed in recent years. It's the way the companies have said how to use it. So if you look at the how to take this medication, the way it's designed is by taking it for 3 weeks and 1 week off. However, the Faculty of Sexual and Reproductive Health say that off license you can actually do a different regime if it's more suitable for the person. So there's different ways of doing it, which we'll show on the next slide. So you can take it for 3 months, have 4 days off. There's different ways of taking a tailored regime, but it is important that you give them the option of whether they take it for 3 weeks, have 1 week off, or they do the tailored regime, which would be whichever's best for the patient. It's really important to highlight to the woman when they're using the combined pill that just because if they're taking it the standard regime, just because they're having the bleed in the week off, doesn't actually mean that she's not pregnant. So that's not a reassuring bleed, because a lot of people historically like to have that week off because they know that they're not pregnant, but that's not the case at all. That's completely untrue. Just because they have the withdrawal bleed doesn't mean they're definitely not pregnant. There is no buildup of menstrual blood inside the woman if they have an extended time without a break. So a lot of women, the reason why they don't want the break is what they think is the more pills they take and the less of a break they have, they think that it's just going to all come together and all of a sudden they'll just have a massive bleed. That is not correct at all. By using doing the extended regime, it just keeps the lining of the womb thin. And the bonus of having a tailored regime is that it can reduce the frequency of withdrawal bleeds and also the withdrawal symptoms associated with it. However, it can cause unscheduled bleeding. So some people like to have the 3 weeks and 1 week off because they know that's when they're going to have their bleeds. Whereas if they take it back to back, they might have breakthrough bleeding, which some women don't like. So it is just kind of giving them the advantages and disadvantages of both ways of taking it, and then they can make an informed decision. The FSRH also advised that written information should always be provided when you're giving contraception. And just to reiterate, if you are prescribing or doing a PGD for the contraception and they decide to use the tailored regime, you should always state that it's outside the manufacturing license. However, it's supported by the FSRH, and you should be informing that to the patient as well. So this is the example taken from the FSRH guidance on the combined pill. So this just states that you can use the standard uses, taking it for 21 days and 7 days off, but you can take it, some of the tailored use is by having a shortened break from the pill. So instead of having 7 days, you have 4, or you can tricycle by taking 3 pills, so 9 weeks together with 4 or 7 days off, or some people can just use it continuous, and that's absolutely fine. There are some really good resources online to help explain the different regimes to your patients. So there's a good leaflet about tricycling from the Oxford NHS and the BMJ. So if you have a Google about that, you can look into that. There's also some nice guidance as well about contraception and a tailored regime. So you can always look at that if you want some more information. So just briefly about the missed pills, it's really important. So the questions that you always need to make sure that you ask is you checking which pill they're using, what their normal regime is. So going back to the pill, you need to see if it's the progesterone-only pill or the combined pill. You need to be checking what their normal pill regime is, if they've had any other missed pills in their packet, and when they last had sex. There is, on average, 57% of women miss an average of 3 or more pills each cycle. So it's really important that you do, when you're providing women with the pill, that you tell them what to do if they miss a pill. So they need to know the missed pill rules and what to do. And just to reiterate, with the progesterone-only pill and the combined pill has completely different windows of taking it. So this is the guidelines about the combined pill. So it just kind of helps you to decide whether that person needs an emergency contraception or not. So they've also got this guidance about the patch and the ring. So it's something that's useful for you to know whereabouts to access it. So just a bit about spotting the signs. I'm not sure if anyone is aware of spotting the signs, but it's a toolkit created by the Brook and Bash. It's basically designed to help people identify if someone under the age of 18 is at risk of sexual exploitation, if they're being harmed in any way, if there's any safeguarding issues. And it's a really good tool. It's got quite a lot of questions, but you wouldn't just fire the questions at the young person. You'd be doing it in a bit of a chatty conversation rather than kind of like question and answer, because you're wanting them to trust you and to give them the information that you're trying to find from them. And just being aware of what your policies and procedures are. If you have got someone that you think might be being exploited, you need to know what to do, like, and who to contact. So I would look at if you Google spotting the signs, it is the updated toolkit. So if you look on the Bash guidance, it will give you a link there, and it's really good, and it's a good read. So if you've already got an under 18s template there that you already use, it might be worth looking at and see if there's any questions that you've missed out on yours that you might want to add to it. So just a bit about hormonal contraception and anti-inflammatory drugs. So there was a study at the beginning of this year, and I can't even say the name, it's Miadi et al. So this study suggests when both hormonal contraception and non-aspirin NSAIDs are used, the VTE risk is higher than with the use of either the hormonal contraception or the non-aspirin NSAIDs alone. But the numbers of the events remain small, so it's really important that you highlight that. So what the FSRH are advising is that the combined hormonal contraception is a higher VTE risk than other methods. So the combined pill or the patch or the ring are a higher risk than other contraceptions. So the progesterone pill, the implant, and the coil a lower risk, and the depot is a medium risk. So you need to be aware of that. And what they have suggested is that clinicians should consider advising users of the combined hormonal contraception about the potential small additional risk if non-aspirin NSAIDs are used along the combined hormonal contraception. So it is worth you yourself having a read of this study. And again, you'll be able to look at this at the FSRH section. It's just a statement to the response. So if you have a look at that as well. So just a bit about an STI overview. So the government have done a report on all the previous screenings for 2022. They do it every year, and it's just in the there's a BASH summary on it as well. So syphilis has increased among gay and bisexual or any other men who are having sex with men, and also heterosexual people. Again, gonorrhea has increased in people of all ages, but as usual, the highest is among young people aged 15 to 24. So what they recommended is regular STI testing, including HIV, on an annual basis if someone is having condomless sex with a new or casual partner, or whenever they change to a new sexual partner. The people who are having sex, men who have sex with men, so gay or bisexual men, or any other man who's having sex with man, should have tests for HIV and other STIs at least annually or every 3 months if they're having condomless sex with new or casual partners. So just to recap, window periods for chlamydia and gonorrhea is 2 weeks, HIV is 45 days, and syphilis is 90 days from potential exposure. So if you're in a clinic and someone says that they've had recent unprotected sex, you can test them, but you need to make them aware of the window periods, as they might want to go back for testing, for repeat testing again. So in regards to vaccines, as you're all probably aware, in 2022, there was an outbreak of monkeypox, so it's now called Mpox. And after that, there were certain members of the population who were eligible for the monkeypox vaccination. It's changed since July 23. The vaccinations for the people who are eligible are now only available in certain areas of the country. So we used to do them all pretty much all around all the different sexual health welcome clinics in the country, but now it's just certain areas. So there's places in Manchester and London that you would have to send someone to if they are needing the monkeypox vaccination. And just to reiterate, if anyone is at risk or is showing symptoms of monkeypox, so having a rash that is consistent with monkeypox, or having any fever, chills, then you need to make sure that you are contacting a specialised sexual health clinic on what the best course of action is. And in regards to hepatitis A, B, and HPV, so A and B is for people who are in a high risk category. If they are in the high risk category, then they need to be referred to sexual health services. And for people who are again in the high risk group, who are under the age of 45 years, they can have the HPV vaccination. It's also worth being aware of PrEP, which is pre-exposure prophylaxis. If someone is likely to have a risk of acquiring HIV, they can get some medication from a specialist sexual health service. And also about PEP, so post-exposure prophylaxis. That's when someone's had some contact with someone, either through sharing needles or any unprotected sex with someone who they think might have HIV, and that can be, they can get it from emergency services like A&E, and also again specialist health services, and you would need to refer them to that or get them to self-refer, but obviously you want to be following them up, really. Just a bit about the useful resources. So we've got, again, I've been banging on about FSRH, but they have got amazing resources there, so I would advise you to look into that. BASH, which is the British Association of Sexual Health, that's a really good resource. Terence Higgins Trust, Brooke as well, who did the Spotting the Signs, so you can use those resources. And of course, you've got the Health Academy, where you've got a new sexual health introduction on there if you want to kind of get your knowledge up to date and start doing contraception. The Health Academy also have other different primary care training as well, which you can look into. And that is it for the sexual health update. Thank you very much for listening.